There's a question at the back, yes.
Recent paper says women respond better than men to radioembolization and small lesions better than large. You comment on that?
You're referring... is this working?
Yeah, it's on.
You are referring to the gastroenterology paper? Yeah, that's for hepatoma. Indeed, we found in our multivariate analysis that there was a difference in response in hepatoma, not neuroendocrine, in response between men and women. In terms of smaller tumors responding better than large, there's no doubt that it's easier to shrink a 4-centimeter tumor to 2 than a 10-centimeter tumor to 7. In the large tumors, anything over 10 centimeters, we still had a 33% partial response rate. So yes, you are correct. Smaller tumors respond better, but large ones still responded at least a respectable amount.
Good. Thank you very much for your lecture. It was very interesting. My question is, what two criteria or one criteria do you use for tumor volume estimation? Do you use a Doppler ultrasound or do you do the programmed CT? And if so, what level of tumor burden do you not do spheres or do you not recommend it?
So the tumor calculation is done specifically and precisely using 3D CT reconstruction. So just like you would calculate future liver remnant following a resection, right, for example, we do the exact same thing. So when we have tumor burden, we know that it's exactly 26.3%, not about 25, right, about 30%.
So where do you cut it?
I'm sorry?
Where do you not do it?
So
what percent?
Boy, that's a tougher question. I don't know that we have a specific cutoff. Certainly, again, there are patients that we have treated with very large tumor burden, over 75%. The problem is those patients have low albumin, they have bad performance status. Those patients are sort of self-selected. Most of our patients that we treated are, in fact, still less than 50% tumor burden. But again, one thing I would caution about the use of tumor burden is most people eyeball tumor burden, and the human eye makes a mistake. We overestimate tumor burden. Yeah. If you look at a scan with the amount of disease, you might think it's 30%. You calculate it, it's actually 15%. Yeah. No, so I think there's a little bit of a discrepancy there.
No, thank you.
Next, there's one person at the microphone. Go to the mic, and I'll call you. Yes, go ahead. Well, he's going.
Well, that was very interesting. For a long time, I've despaired that we could have meaningful clinical trials with neuroendocrine tumors because of the heterogeneity of the presentations. And in the experiences I've had doing clinical trials, one has to screen many patients in order to include one in a meaningful trial. I'm encouraged by what I hear, particularly from Dr. Koenneke, but I wonder if these trials go forward, will we actually run out of available patients, and will these trials get in each other's way? Do we have a traffic cop that's looking after this?
That's a really good question, and really what a lot of it boils down to is trial design, and again, talking about the stratification factors. So do you allow patients who have been pre-treated with mTOR inhibitors to enter a trial evaluating the value of, let's say, Sutent? And because we realize that there are, the patient population is small, usually the answer to that is, you try to make it work. And that's I think, good trial design, as long as it's not, an agent that is really targeting the same pathway. Then, if it's two different chemotherapeutics, it's dicey. If it's both targeting the anti-angiogenic pathway, it's dicey. But if it's if it's a different pathway, I think you can make an argument that you should allow that.
Dan?
Just maybe add a comment. I mean, certainly in other disease types, that is a major phenomena. For instance, breast cancer. As we've learned more about molecular profiles, that clinical trials actually target very specific subpopulations amongst breast cancer patients, which results in, exactly as you say, much more difficult accrual, and you have to screen many more to accrue fewer. And I think we're still a bit away from that for neuroendocrine tumors, but I think as the preclinical pathways start being elucidated, no doubt we'll face the same thing.
My second question, thank you for that, is concerning, it seems to me that these trials take a very long time, and what's happened is that things that are being questioned as being not standard of care in this country have moved into standard of care in other countries. And so people are looking over the fence and they're saying, why can't I get this treatment in Canada when I can get it in Germany or Sweden? And this is creating a perception that we're not sort of staying with the game. I've wondered for a long time whether we couldn't, in place of clinical trials in some of these situations, develop registries that would be prospective, that could be in some way harmonized so that standard protocols would be followed and that we could collect on an international basis and come to conclusions much more quickly.
Thank you for that comment. That's very important. Yes, you have a question.
Are there any similar techniques being used for neuroendocrine cancers in the pancreas?
Sorry, I don't think we
Are these techniques
The
applicable?
yttrium beads you're talking about?
Yes.
The yttrium, so that's a question for...
Yeah, yes. I mean, right now, the stage where we have, you're talking about the liver-directed therapy?
Yes.
Yes, absolutely. So there are many patients that we see, and again, it tends to be heterogeneous at this point because of the lack of focus of the clinical trial development, but there are patients that, in that scenario, have progressing liver disease where we have treated them and we continue to treat them given the lack of other options. So the answer is yes.
And similar levels of results?
Depends. Depends, unfortunately, on tumor burden, how much disease there is, exposure to previous agents. A lot of patients now we're seeing have been exposed to a lot of the biologics. Didn't exist 5 years ago. Now a patient on Avastin and Erbitux, the vasculature is now being affected. You saw some of the scans that some of the previous speakers showed. A necrotic tumor, that's vascularity that's being affected. The blood flow to the tumor. Remember the rationale I said, because these tumors are hypervascular, that's why this works. If you obliterate that vascularity, that very advantage is now gone. That's why when I think about clinical trial design between these two things, I'd like to do sort of the liver therapy first and then augment with the agent that will stop the blood flow after, as opposed to the reverse, which is what we see right now.
Tony?
Sorry, this is a question for Dr. Salem. There's a debate right now in pituitary tumors looking at the effect of somatostatin analogs to inhibit susceptibility to stereotactic and external beam irradiation. And I just wonder, is there any data on that? Has it ever been looked at? And do you think it might apply to internal radiation?
I'm not sure. The combination of stereotactic body radiation with sandostatin,
With
for example?
sandostatin, yeah.
Yeah, there are a number of studies suggest that the somatostatin analogs actually inhibit the efficacy of radiation treatment in pituitary tumors.
Yes, so this is, that is correct. There is data that shows this. The difference being here is that what we are delivering with this therapy now is magnitudes higher radiation than we're used to seeing. Mm-hmm. So when you talk about a dose fractionation schedule of the liver, say 2 gray a day for 40 days, whatever it is, total of 40, 50, 60 gray, we're administering hundreds, if not thousands of gray with this because of the very high specific activities, microspheres. So these are radiation activities and doses that are way higher than we're used to seeing. So I think that's why we're seeing some of the very dramatic effects, and I think it offsets all of that we've seen with the radiation oncology literature. And that's why I think we see what we see, and hopefully if you guys come tomorrow, I have a lot of very dramatic images, including pathology data to show you about the specific effect of this on tumor, which is really the proof of concept.
But has anyone looked to see if you get even better efficacy if you omitted the somatostatin analogs for a time?
I don't believe so. I don't believe so, not to my knowledge.
I mean, it becomes a bit of a practical question, too. I think I'd be a bit reluctant to stop the agents in a patient with a secretory tumor.
Thank you very much. You can shrink, just with an IV infusion, you can shrink the flow by 25% with a single bolus of octreotide. A follow-up to that question, though, and as we look at the different algorithms of care in the group, you know, the option for some folks are that they can go to Europe and get Y90 systemic, which delivers, as you say, a lot less direct dose to the liver. And there might be evidence that says that the Y90 spheres precludes effective treatment when you do systemic. Is there ever a point where you or your group might decide a different algorithm or an order of which you would pursue that?
Yeah, I think. Sorry. So I think when you have significant extrahepatic disease, there's no doubt that I think that's the rationale that we choose. But our approach tends to be, if you have liver-dominant, liver-focused disease, that's what we would like to target as much as possible. And really, one of the things that we've observed over 10 years is a little bit like the transplant observation, right? There's no randomized data for liver transplantation, yet the effects are so dramatic that this is now the standard of care. We're not there yet with Y90, but when you see 20-centimeter tumors shrink to 5 or 4 or 3 centimeters with a frequency of about 15 to 20%, that is extremely dramatic. We don't see that with other embolics, which is what we used to do before we had Y90. So I think it's that proof of concept that is really, really very intriguing with this. So liver only, we tend to do it. Otherwise, absolutely, they go for systemic.
Thank you.
So just before we close up, I have a few questions from patients that have been kindly brought up here. And I'm going to read these. I'm not going to answer them. So the first one, which actually 10 people have asked, of any of the doctors in the room, so don't go away, can you please speak to the potential role played by environmental toxins such as benzene in causing neuroendocrine tumors? Would anybody like to hazard a response to that? I'm not getting any uptake from anybody. The answer is we don't know. So that answers 10 people's questions. I have a couple of others because I think we do have maybe 2 more minutes. 5 more minutes, okay.
I have a question, too.
Yes.
Well, go ahead.
Okay. So this is for anybody. Octreotide levels, do we need to do them to assess, now I can't read all this, to assess the doses of long-acting octreotide that we use, and do we need to assess somatostatin receptor levels to assess before use? So, who'd like to tackle that one? Who's our somatostatin expert? Tom, do you want to deal with that?
Well, I'll just try it. I'm kind of a disciple of Woldering. I think in light of that newer work that's now suggesting that more, at least the presence of octreotide right before a procedure, a surgical procedure, seems to be associated with more internalization, and that's what we heard from Roybe's paper, was that quick bolus of 50 micrograms, and that's been shown a long time ago, that would be an acute high level into the 1,000 picogram range, is associated with sort of juicing up the internalization phenomena, which if it doesn't get inside the cell, it's not going to work. So, and Gene always points to the 10,000 picogram per mil, and the answer is more better. It may well be, and I think we have to be cognizant of that. I also think the other side of the coin is you can blunt the effectiveness of systemic therapy, but I think this work is going to keep going, and it's going to show that higher levels are going to be better. And we have 90 people on the subcutaneous infusion pump in the United States, and I can achieve 10 to 15,000 picograms per mil, and I can see in 3 years' time they're not progressing. And we will say this, we'll sing the message, but right now we're putting it together. But I just don't have a doubt. And I do think LAR doesn't deliver that. The more you take, the higher the dose, the less you get in there, period.
I think just from a clinical perspective, most of us, for patients who have syndrome, follow the symptom control to assess dose. And we know that 40 to 50%, if not 60% of all patients on LAR over time will need rescues. So there must, and will respond to rescue dosing of either short-acting or dose escalation of the LAR. So there must be something to do with dose or how it binds to the receptors, but I don't think anyone's ever really studied that terribly well. As far as needing functioning somatostatin receptors in Octreoscan, if you look at the data from the PROMID trial, which is the pivotal trial we have now looking at LAR for anti-proliferative effect, an positive Octreoscan wasn't a requirement to enter into the study, so I think the obligation of that is still unclear.
Now I have 2 questions, one for Dr. Ardil and one for Dr. DeHerter. So if they're here, can you please come to the microphone so we'll hear your answer? I don't know if they're in the room. Okay.
Can I ask a question?
Sure.
Right. I guess the question is to my panelists, if I may. About 7 years ago, when we first, after a few years of working with this kind of therapy, local regional therapies, including Y90, we tried to design a few clinical trials. And I'm an interventional radiologist, so I had to study the chemotherapy rationale for neuroendocrine tumors, and I had to study sort of the NCCN guidelines and what is accepted and what's not accepted. And some of the designs that we came up with included controlling, having patients that were progressing to interferon and others to best supportive care. And those were very quickly dismissed long ago as unethical, difficult to complete, but yet I see spectacular studies and spectacular results now with these very designs. And I'm wondering, just for me, what is it that I could learn from that experience? Because now everything is, or a lot of them are, with interferon and best supportive care. And I don't know how right now I could design such a trial, yet they are being done. So what am I missing?
Well, I think, as you say, the playing field has changed, and we are, although biologically we'd like to have a much cleaner picture, I think clinically, if we want to get, trials done, and, one of the slides I had up there was consensus that a washout requirement of somatostatin therapy should be discouraged for patients who are being tested to evaluate novel somatostatin therapy. So that, I think, that paradigm has shifted in favor of a little bit more patient-focused and more of a real-life scenario. You may have noticed that the trial designs that we've advocated, and we argued a lot about this actually, is whether or not we should specify no octreotide therapy or octreotide therapy among patients who are being tested for the benefit of Sutent, for example. And we went back and forth. We actually had a vote in the room. I don't know whether you were there, but maybe in a different session. But, it was about 50-50. But in the end of the day, we were more pragmatic, and the answer was we were going to stratify for it. So that's kind of the way of dealing with it.
Just from a quick general point of view, I mean, we're two trains going the same direction on different tracks, and somehow we've got to find a way to integrate these two types of therapy, because without, and it's going to take a lot of creative trial design, it's going to take a change of concepts, it's going to take a lot of learning from both sides and how to integrate, and it may be stratifying local regional predominant disease versus systemic predominant disease, one type of therapy followed by the other at progression. So I really do think actually there are ways to do this that probably are much more palatable and feasible now than they were, let's say, 10 years ago, when really from a systemic point of view, it was all a lot of nihilism and not a lot of...
But it's generally agreed now that progression-free survival, not overall survival endpoints, is perfectly adequate and acceptable for neuroendocrine tumors. Yes.
I would say the answer to that is yes, yeah.
Are there any other questions? Yes.
I have a comment about one of the questions you asked about benzene and carcinoid. I don't know the answer, but if the only place I guess you know the answer is the IARC, International Agency for Research of Cancer. So there's a website. You might have some information about that. So just a comment.
I think we'll call this session to a close to give people time just to relax a little bit. And would you like to make some more announcements, Jim?